Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals with me, Catherine Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While NICU parent scars are not as visible, NICU parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Howdy, y'all, and welcome back to NICU Heroes. I hope that y'all have been enjoying these experts in all these different places and spaces of neonatology and how they can help make you a better NICU professional. I know that many of you are listening to this enjoying continuing education credits, and I will tell you that as someone who is not necessarily in the medical profession, I went to NICU school as a mom, but I am absolutely fascinated and also encouraged by what I'm hearing that professionals are doing out in the world. And today's specialist is unique and she is amazing. And I know that you're really going to take a lot away from our conversation. She is a neonatologist in addition to an optometrist. And our conversation today will focus on ROP, retinopathy of prematurity. And I know that there are lots of intricacies when it comes to learning about ROP. What are the symptoms? What are the causes? What are the treatments? And we are going to tackle all of that in our conversation. So my guest today is Dr. Olachi Mezu-Ndubuisi. She's an associate professor of pediatrics and ophthalmology with tenure at the University of Rochester, New York, and the McPherson Eye Center Institute's Retina Research Foundation, Edwin and Dorothy Gamewell professor. Dr. Mezu-Ndubuisi's dual expertise as both a licensed optometrist and neonatologist has enabled her to develop a unique research niche studying retinopathy of prematurity, or ROP, and the effects of oxidative stress on developing organs in both laboratory and clinical research. Dr. Mezu-Ndubuisi has over 22 academic research publications, including 4 book chapters, and participates in humanitarian global health activities with a commitment to an integrated career path of research, teaching, and service. She is amazing. So with that, let's chat. Well, I'm really honored to have an expert in the room. She's not only a neonatologist, but she's also an optometrist, Olachi Mezu-Ndubuisi. I'm so grateful that you're here.
Thank you for having me. It's a pleasure.
No, we have a lot to talk about. I think that you are unique in that you are a neonatologist, but you're also an optometrist. And I'm really curious how that happened because you were the first person that I've ever heard that has those two specialties together, and you still practice and do both of those. So I'm really curious how that all came to be.
Yes, thank you. I think neonatology and optometry provide for me the best of both worlds through the unique niche I was blessed to find in retinopathy of prematurity, ROP, which is my research area of interest. I did not know that I would do both, but following my passion, which is what I love and enjoy doing, and sort of having a bigger selfless purpose for my passion and seeking and staying where I am valued, led me down this path, I would say. So I guess a little bit, I grew up in the tropical southeastern part of Nigeria in a close-knit family of 10 children, including a twin sister, raised by our doctorally trained parents who instilled a love of learning and a passion for service. And there's 7 girls. One's a lawyer, accountant, 3 subspecialty medical doctors, 2 pharmacists, 1 optometrist, public health specialist, and 3 boys who are engineers and information technology specialists. So my earliest desire or vocation was in elementary school, and I wanted to be a teacher. I loved learning and sharing knowledge with others. This evolved soon into a natural desire to be a medical doctor to help alleviate the suffering of others. It was disheartening for me to see so many suffer from preventable medical illnesses due to inability to either afford care or lack of access to health care. So I took my college entrance exams a year ahead of my peers and was accepted into a 6-year Doctor of Optometry program at the age of 15. I loved the eyes and organ and enjoyed learning about it. Upon completing my doctorate in optometry OD at Abia State University in Nigeria, the desire to be a medical doctor became stronger than ever. I migrated to the United States with my family and obtained my medical degree from Ross University School of Medicine and also got my license to practice optometry in the US. I did my pediatrics residency in Louisiana State University, Shreveport, where I was drawn to the neonatal intensive care unit, the NICU. The thrill of the organized intensity, the reverence for the suffering innocent babies, and the strength in their families' vulnerability really brought a calm to my soul. I began my neonatology fellowship after residency at University of Maryland, Baltimore in July 2006, and it was suddenly disrupted by complications of a high-risk twin pregnancy from severe preeclampsia. It was a challenging and one of the most meaningful experiences of my life, for which I am grateful. I delivered premature twins born at 26 weeks gestation at 1 pound birth weight. My son, Obiola, helped bring his sister, Olarose, safely into the world, and after 6 brave days, he rested ever so gently. Olarose, my daughter, was extremely fragile at 470-gram birth weight and could fit in the palm of one hand. She came home to my joy after 3 months in the NICU without any neurodevelopmental deficits. My experiences as a NICU mother sort of gave me a deeper appreciation for the evolving field of neonatology and the unspoken heroism of the NICU staff in their selfless care of humanity's smallest and most fragile members. Olarose is now a healthy 16-year-old author, poet, and artist starting 11th grade and has a quiet confidence and a kind heart. She inspires me to do what I do every day and continue to love what I do, caring for brave little miracles and angels like her and her brother. So after a few months back at work, I took a break from fellowship in order to focus on my daughter's medical and developmental needs at the time. I went to work in the community hospital, NICU, as a neonatal pediatrician covering the NICU at night. I then realized after a couple of years of doing that I truly loved neonatology and I wanted to complete my fellowship. I accepted a position in University of Illinois, Chicago at around the spring of 2011. And during fellowship there, one had to have a scholarly project. I naturally chose to study ROP, being the most prevalent eye condition in the NICU due to my background in optometry. I was passionate about developing a clinical project on ROP, either looking at risk factors, outcomes, or outpatient follow-up. But as I poured through the existing literature, I found myself studying vascular biology and angiogenesis journals. And I was in awe at the wealth of knowledge seemingly stocked for decades in these basic science journals from animal studies, sort of awaiting clinical bedside translation. I found the information in them that could really help us better understand and manage not just ROP, but lung disease and other diseases of prematurity. I was fascinated. I realized that to make an impact or a difference, I needed to learn how to study ROP using an animal model. I had no prior lab research training, and there was no one in my institution studying ROP. But I had great mentors who were very supportive of me following my passion for eye research. I was connected to a PhD researcher who studied chronic lung disease in mice, and I learned how to handle and breed mice and use his oxygen chamber to expose my mice to oxygen. Then I was connected to another PhD researcher in ophthalmology, studying oxygen tension in a rat model of adult inherited retinal disease. Well, to study ROP mice, one had to do whole mounts of flat mount, which is done by enucleating the eyeballs, dissecting out the retina, and sort of flattening it on a slide. And then you stain it with a dye to visualize the vessels under a microscope. Well, there was no one doing flat mounts, whole mounts in my institution at that time, and watching YouTube videos didn't help. That's when I asked that question, why can I not look into the eyes of a mouse and visualize retinal vessels like I would a baby? And I was told it was impossible, but I decided to find out. We found that it was possible to pry open the eyes of these mice. We dilated the pupils and devised a method to inject fluorescein intraperitoneally in their abdominal cavity, which enabled us to visualize retinal vessels because the fluorescein would spill into the vascular system and end up in the eye. That's how I developed the protocol. for in vivo or live imaging in mice with oxygen-induced retinopathy or OIR. So I guess in a nutshell, I feel really blessed to have the opportunity to do what I love and combine my passion for teaching, eye care, clinical and research work as both a neonatologist um, and a vision scientist through my research in ROP, and also studying the effects of oxidative stress on the fragile developing organs of premature infants. I hope to continue to contribute to new understanding of disease mechanisms that will help us identify safe and effective therapies for ROP and other vasoproliferative diseases, which would improve health outcomes, not just nationally here in the US, but globally.
Thank you for sharing a little bit of your. I know you shared a lot about your research and your love, but I know that NICU professionals who are listening probably appreciate most you sharing a little bit of your personal story, that of your own experience as a NICU mom. I think sometimes we can read about things and see things and come to understand them in some ways, but it's not until we have a life experience that plunges us into a place that we thought we knew, and then you walk out with a completely different perspective, which I know probably is a real benefit to your research that you do, but also to how you parent your daughter and how you treat your patients. It must be a real benefit. I can only imagine what that did. So I know sometimes when people hear optometry and ophthalmology, our tendency is to use those interchangeably, but I don't think we can. So, can you tell us a little bit about what's the difference between optometry and ophthalmology?
Yes, definitely. Optometry and ophthalmology, I think they're both healthcare professionals dedicated to the um, care of the eye and eye diseases and conditions. Both professions, however, differ in the training and specific expertise of the eye they focus on. An optometrist, after 4 years of college or 2 years of prerequisite college courses in some programs around the world, receives an additional 4 years of training in the College of Optometry to obtain a Doctor of Optometry degree, OD. An optometrist also treats eye diseases, corrects refractive errors, fits and manages contact lenses and eye muscle imbalance with visual training or glasses, but they do not perform major eye surgeries. They are trained to perform some minor eye surgical procedures like foreign body removals, chalazion extractions, lacrimal duct or tear duct probing, for example. Then, an ophthalmologist, after college or 2 years of pre-medical courses, goes to 4 years of medical school to obtain a Doctor of Medicine degree, MD, and then completes an internship year in general medicine or surgery, followed by a 3 year residency to specialize in ophthalmology. Then the ophthalmologist is the one that treats all eye conditions or diseases, including both refractive errors, correction, and can perform all eye surgery. You can also have subspecialty training in both ophthalmology and optometry in specific parts of the eye, like a cornea specialist or a glaucoma specialist, retina, or ocular genetics. So optometrists and ophthalmologists really work together to provide holistic care to the community. In the NICU, however, is the ophthalmologist that would be performing the dilated retinal exams for babies to diagnose and treat ROP. They will be the ones to follow up ROP exams in the NICU and as an outpatient after NICU discharge. However, the optometrist should be aware that they may be seeing ROP patients during routine eye exams or school vision tests. The ophthalmologist caring for the ROP patient could be either a general ophthalmologist, a pediatric ophthalmologist, or a retinal surgeon, depending on the subspecialty that
Sure.
is available in the hospital or region. And they both, optometrists and ophthalmologists, play unique roles in eye care. And I'm blessed to have a deeper appreciation and respect for both roles in eye care.
No, you know what I love about specialists is that so our son has a nephrologist, so kidney specialist, and he loves the kidney, like it is his favorite organ. And so as I'm listening to you speak, I'm like, you really love the eye, and I think that that's what makes a good specialist, is someone who believes without a doubt that the organ that they specialize in is incredibly important, and they see how it connects to all the other body parts. So thank you for sharing a little bit of your passion. I love hearing that. So I know, and you sort of answered this a little bit about how that really drives your research, but I know, so in your bio, which everyone heard at the beginning, but I want to mention it again, is so you say that you're passionate from bench to bedside translational research with a humanistic goal of developing safer therapies and informing new paradigms for more effective clinical management strategies. So maybe explain a little bit about what that passion is and why it's sort of led you in the direction that you're going.
Yeah, thank you for asking that. Research, I believe, should have a humanistic goal of seeking to improve health outcomes of our fellow humans. And this care should really not be limited to our region of the world, but should be applicable to every person, adult, child, or soul in any part of the world. I believe the goal of research shouldn't just be a cycle of amount of funding or grants of publication or accolades or even novel discoveries, but rather should have that humanistic goal for the researcher to seek to understand disease mechanisms and pathogenesis. And this is what will help us find safer, non-toxic therapies to improve the outcomes of our patients. Um, I know, and most importantly, research findings should not be applicable to just the hospital we're working with or our state or region or country, but globally, especially as far away as resource limited countries or remote villages in the world. So that is the humanistic goal, that where you care about every single person's well-being, not just those you know or love. And I think the COVID-19 pandemic and its devastating effects have raised all our consciousness of global health and service beyond our borders, that we're all connected in this one world and we need to care about people's well-being in other parts of the world. And just growing up from my background in Nigeria, where there's limited access to healthcare that's impacted quality of life for both children and adults, I made that commitment to service, to improve global health inequities. So yes, I have been motivated to care for premature babies and their fragile developing organs through my research and clinical work, and also to look at various factors and things that could reduce their exposures to long-term deficits. So I do this in my basic science lab by characterizing ROP beyond just retinal vascular development, but studying its other features like structural and functional phenotypes or mechanisms of disease. And as well, I'm currently now investigating other therapies that could be useful for ROP and other diseases for the premature infant.
Well, I know we talked a lot about ROP. You've mentioned it, but I think it
Yeah.
might be helpful because I think sometimes in the NICU, because it's so prevalent that we sometimes just assume that people, one, know what the acronym stands for, and two, they know what it encompasses. So maybe tell us, what does ROP stand for and what causes it? And what are some of the symptoms that I think if you're a NICU professional that you may be seeing with some of your babies in the NICU?
Yes. Thank you for that question. So RP stands for Retinopathy of Prematurity, and it is a potentially blinding eye disease of abnormal retinal vascular development that occurs in premature infants. And this is following the use of supplemental oxygen for their immature lungs. So technically, there's no known cure for RP, and that's why it has remained the leading cause of avoidable childhood blindness worldwide. The incidence and prevalence is seen an increase in severity when the infants of younger gestational ages have lower birth weights. So gestational ages less than 32 weeks, 30 weeks, and lower birth weight as low as below 1,500 grams and 1,000 grams. So how does it all start? Well, the retinal vessels develop in utero in a low oxygen environment. Um, they develop through a process of vasculogenesis where the early vascular primordial cords form the superficial retinal plexus. And then much later, they develop by angiogenesis where new vessels form from existing vessels to populate the deeper retinal plexus. And this starts about 16 weeks of gestation in the womb. And the retinal vessels start to grow from the optic nerve outwards. And you have the nasal retina being fully vascularized by 36 weeks and the temporal retina by 40 weeks. So you can see that when you have a baby being born premature, you're disrupting the vessel growth in the retina because they haven't gotten to the full peripheral retinal vascularization at 36 or 40 weeks. And this creates an avascular retinal periphery. And in utero, that hypoxia is physiologic. The oxygen tension numbers in the womb is as low as 25 to 30 millimeters of mercury compared to room air that you and I are breathing. When that baby is born into room air, that alone is hyperoxia or too much oxygen for the premature baby because they're now breathing about 100 millimeters of mercury. This is without any supplemental oxygen. So in utero hypoxia also allows growth factors that are necessary for blood vessel growth to be released by the baby's body. And this includes one of the most significant ones, vascular endothelial growth factor, VEGF. And you hear me probably say that a few more times here. And when the baby is now born, the baby is cut off from placental and amniotic fluid proteins and growth factor like VEGF or insulin growth factor 1 that help the baby's blood vessels to grow. And these blood vessels need to grow not just in the retina, but in the lungs and the kidneys and the brain. So now being born into a hyperoxic exurine environment, hyperoxia downregulates those growth factors that were produced in low oxygen in the womb. So it disrupts angiogenesis or blood vessel formation. And now we're exacerbated by the babies do need sometimes supplemental oxygen being premature because they lack surfactant, their lungs are immature. So they need to have lungs inflated to allow adequate oxygen exchange. Well, that causes oxidative stress because there's now too much oxygen being delivered to the body of the baby that the baby's antioxidant mechanisms can counteract.
So you're saying that if a baby, they obviously need oxygen to live, but as the doctors are giving those babies oxygen, they're sort of exacerbating the incidence, you think, of ROP because of the development process?
Yes, ROP starts from the minute the baby is born. Just that phase of ROP we don't see clinically because we can't start eye exams until 4 to 6 weeks later. But it starts the minute that baby is born. And that's the phase 1 or vasoobliteration that occurs in high oxygen. And then in 4 to 6 weeks later, as the baby matures, you now don't have enough blood vessels to nourish the retina. And the retina is one of the most vascularized and highly metabolically active tissues in the body because it has a network of cells and synapses that connect with each other. And they want oxygen, they want nutrition, they want to carry away CO2 and waste products. So if there are not enough blood vessels to serve those purpose, then the retina becomes hypoxic and now releases excess of those growth factors, especially VEGF, the vascular endothelial growth factor. And that causes abnormal vessels to form and bleeding in the eye. And that's the second phase of ROP called vasoobliteration or pathologic neovascularization. And that, if not treated right away, can cause bleeding that's worse and eventual retinal detachment, which leads to blindness.
So what are the treatment options? I know you talked about that there's no cure, but when a doctor may suspect that a baby's maybe risk of ROP may be higher, or they're starting to see things that are like, yep, now I see the body starting to kick in to start to repair it when actually it's doing some damage to it. What are some things that you can do to sort of mitigate or lessen the extremity of ROP?
Yes. So first, the dilated eye exams are key. So they start in the NICU by the ophthalmologist at about 31 weeks post-menstrual age or 4 to 6 weeks after birth. If the baby had excess oxygen exposure initially, may be at risk for abnormal new vessels forming. So first of all, you want to identify the at most risk babies. These are babies that have very low birth weight, less than 1,500 grams, or born at gestational ages of 30 weeks or less. And sometimes you do screen bigger babies who are more than 1,500, as high as 2,000 or higher birth rate, and gestational age more than 30 weeks. If they're clinically unstable, have a critical illness they're being treated for, had prolonged oxygen use, or at the request of the neonatologist. So there is a certain burden on the eye exam. So we've really worked hard to identify at-risk babies. Regarding treatment, the decision to treat a baby is based on the severity of disease. We have the current classification based on the early treatment of ROP studies, looks at type 1 ROP, which is threshold, the former threshold disease, or type 2 ROP, which is pre-threshold disease. If you have pre-threshold disease or type 2 ROP, that will be a stage 1 or 2 ROP, and I'll go through the stages later without plus disease. You can just monitor those babies with serial exams. And if you have type 1 ROP, which is the threshold disease, which would be zone 1 ROP at any stage, or zone 1 stage 3, and a zone 2 stage 2, those get treatment within 48 to 72 hours to prevent risk of progression and blindness. So the treatment options have sort of varied over the years with more research in the like in the 80s and early 90s. We had the CryoRop study that showed us that we could improve our structural outcomes. And with cryotherapy, which is basically a freezer burn to the eye. So those are used in later stages. But then as we progressed to the 90s, we had laser therapy of laser photocoagulation, which is you shoot an indirect laser beams to the avascular periphery, which is the goal of treatment, to reduce the hypoxic stimuli coming from the avascular retinal periphery. So those laser therapy can also actually reduce physical vision because you're basically having full thickness burns through the peripheral retina. So it's the current standard of care. You could have destruction of the retinal layers that have laser burns, and you would able to see the underlying choroidal vessels. And that's for the stages of ROP, like stage 3. But when you have detachment of the retina, partial or total, you would be needing more intense retinal surgery like sclerobuccal surgery, where they fix a band around the sclera, or vitrectomy, where the doctor makes small openings in the eyes to remove most of the bleeding from around the vitreous. And now, most recently, in the past decade and a half, we've had drug therapies being developed that have worked for small cell lung cancer and other cancers that are now being off-label used for ROP treatment. So they're injected into the eye through intravitreally, and they help to stop bleeding. So they're anti-VEGF therapies. So they compete with VEGF for the receptor, and they block the effect of VEGF in the retina. But the potential risks of this anti-VEGF therapy, and there are several of them out there, is that there's systemic absorption, and VEGF is short-acting. They need repeated doses. And this anti-VEGF therapy actually not only just block one type of VEGF, they block several, more than 2 types of VEGF, and some of them block all forms of VEGF. The concern with that is that we need VEGF for vessel formation, not just in the retina, but the lungs and brains and kidneys. So that poses a concern about vessel growth in other parts of the fragile organs that are developing. And sometimes the VEGF therapy allows normal retinal growth to continue, but it would mean that you would have to follow up those babies much longer. They're at risk for reactivation. So these are the treatment options that are currently available.
None of those sound like they are easy decisions to make as I'm listening to you
Yeah,
say that, because
yeah,
it sounds like doctors are having to weigh, do we intervene and save
yeah,
the eyesight, but then do the other organs become, to the
yeah,
detriment of the other organs? So it's
yeah,
this balance. It sounds like
yeah.
every baby is unique, and every situation is unique. While I'm sure that there are some certain rubrics and standards that you follow, it still sounds complicated. You're making it sound easy, but I'm also listening and saying, I'm glad that there are people who understand what causes it, because then it helps you
Yeah.
maybe understand, like, whether it's their weight or their gestational age, helping you figure out, okay, so we know these things, so let's try this because we feel like it may be the best course of action for this particular baby.
Well, that brings me to a part that I wanted to say something about prevention. It's a very important point. While there's no known drug cure to prevent it, because sometimes prematurity is something you don't have control over. If the mom's life is in danger, or the baby's health is in danger in the womb, and the baby needs to come out premature. So through studies, especially animal studies, we've learned about oxygen saturation targeting, and knowing how the mechanism of ROP occurs, meaning that it starts when the baby is born into too high oxygen. We've seen that targeting lower oxygen saturations, enough to just giving the baby just enough oxygen to inflate the lungs, and starting
Right.
to wean or reduce your oxygen use once that goal is reached. You have well expanded chest X-ray, the lungs that look well, blood, capillary and arterial blood gases that look well oxygenated. You start to wean because that high oxygen is what starts the ROP. And the degree in that phase 1, where you have downregulation of VEGF that causes vessel loss or vasoablation, the longer the baby has that happening, then the more severe the second phase. So oxygen saturation has been a very controversial topic, we've had randomized controlled trials that have been done to look at what is the target. Oxygen is a drug, I like to say, and we should only use how much we need for just the minimal amount we need. So the studies have shown that if you targeted low oxygen saturation, like 85 to 89%, like the Neoprom studies that looked at several trials, the support trial, boost trials in UK, Australia, New Zealand, and CART or Canadian oxygen trials, they showed that lower saturation targeted throughout the stay of the NICU life for the baby decreased the incidence of ROP and lung disease or bronchopulmonary dysplasia, but increased the risk of mortality at 36 weeks post-menstrual age at a rate of 21.8% versus 13.3%, compared to the high oxygen group that was maintained at 91 to 95%. And this was a collaborative meta-analysis done in about 4,911 infants born less than 28 weeks. So that raised concerns about, even though we reduced the incidence of ROP by targeting lower SATs, we had more babies being at risk for mortality. So the American Academy of Pediatrics sort of recommended by 2016 that we should target just SATs about 90 to 95 in extremely low birth weight babies, and that was safer than 85 to 89. But from our animal studies and understanding of the mechanism of ROP, I feel some of those studies may have been flawed because they did not take account the two-phase biphasic pathogenesis of ROP. So if you're targeting lower SAT, it should just be the first 4 to 6 weeks of life. After that, the SATs need to go higher. You need to target higher SATs to decrease the angiogenic stimuli from excess VEGF production after 4 to 6 weeks of life. So I'm hoping that in the future, more clinical trials would follow this biphasic guideline and help reduce the incidence of ROP, as we've shown in some single-center studies in Iowa and Los Angeles that show that targeting a biphasic or graded oxygen saturation algorithm reduced ROP and also did not have any effect on mortality in both groups.
Wow. Well, I mean, I know that your bio lists many research projects that you have been a part of, and I'm sure some clinical trials as well. What do you think? I know you alluded to it a little bit. What do you think the most promising clinical trial or the most promising treatment option that you're seeing through your research that people can start to look forward to using in the NICU?
Yes, there are a lot of things going on out there. So I think most important is, for me, is identifying what are the concerns about ROP clinical care in the NICU. And that's what I try to do when I started my research, to understand what are the existing gaps in knowledge in current literature. That basically drove my hypothesis. So one is the increase in number of preterm births. As we've had advances in perinatal and neonatal technologies, there's been an increase in burden on ROP screening. There's a limited number of ophthalmologists to do this eye exams, and they can cause a lot of stress on the critically ill premature babies. So my research has confirmed that body weight is a consistent risk factor for severe ROP. So when I'm working with the mice, we have found that we need to control the number of mice to about 6 pups a cage during oxygen-induced retinopathy, because if there are larger litters than 6 in the oxygen chamber with their mom, they're competing for nutrition and they come out smaller. That growth restriction gives us a more abnormal or vascular phenotype. And that has been confirmed in a lot of studies that show that optimal nutrition, especially with breast milk, and adequate postnatal growth affected or reduced the severity of ROP. So that's one thing. And then one of the concerns also with current ROP is the objective nature, very subjective nature of diagnosis. There's not a standardized objective method to diagnose ROP. This has been a challenge clinically and in research ROP trials. So we need a more reliable, objective way first to diagnose ROP, because if there's a discrepancy within the reading for a stage 2 or stage 3 plus disease or not, that could delay critical treatment, which needs to happen within 48 to 72 hours. So having an objective method would be helpful. So I worked on developing a quantitative method of assessing the abnormal vascular parameters that I saw in the mice with oxygen-induced retinopathy, like the retinal vascular coverage, retinal vein width, and retinal arterial tortuosity. And I developed a software with bioinformatic experts that we've made publicly available at quantbv.com. And that has been used by researchers to quantify these abnormal vessels, not just in the retina, but other vascular tissues beyond ROP. So my research has shown that if the capillary avascularity recovered as the mice got older, and the vein dilation did recover, and those and the arterial tortuosity got a little bit better. So vein dilation and arterial tortuosity are markers of severe ROP in the babies. But what was consistent was that arterial tortuosity, even though it got less with age of the mice, it persisted throughout the developmental maturity of the mouse. So that could be a very more reliable marker for ROP severity and diagnosis. The most important in treatment for me is maintaining and adhering to the biphasic pathogenic mechanisms of ROP. Treatments in phase 1 to prevent vasoobliteration should be targeted to either allow shortly after birth in the first 4 to 6 weeks of life, allow normal retinal vascular development by reducing how much oxygen the baby is exposed to, either through the ventilator and the tracheal tube connected to the ventilator, or through non-invasive methods like devices like CPAP. Right. And then 4 to 6 weeks later, knowing that you should avoid fluctuations in oxygen tension, hypoxic episodes, because that hypoxic stimuli in the phase 2 will drive abnormal vessel bleeding. And also for me, I'm very passionate about an integration of care, knowing that whatever you give to the lungs affects the retina, and the treatments for ROP go in line with treatments for BPD, inhibiting or minimizing inflammation, avoiding excess fluid administration that prolong the need for oxygen use supplemented or through the ventilator. So having a more integrated care and understanding that all this lung disease and ROP share similar pathogenesis and mechanism would be overall helpful for the babies and help preserve vision.
Yeah, I mean, I'm listening to you share all that. I mean, it's reminding me of like when we look at like early intervention, like when our child may have like a developmental delay, the earlier that we intervene, the better the long-term prognosis. And so it's sounding like as you start to look at that top one, what intervention do you start with, and then sort of the dominoes that fall after that. But also just, I mean, I'm thinking of how important it is to have an optometrist or an ophthalmologist there to consult so that the treatment options do make sense, but also that we recognize the interconnectivity of all the organs, that what you do to one isn't just isolated. It's not just to the eyes, but it affects all the other things. Like our son had issues with his gut, and I did not know how many things were connected to the gut and the health of the gut and what that means. So I think that the interconnectivity of it, you're driving that point home. I'm glad that you mentioned all of that. I know I'm going to have you put on, so I know you have your optometrist neonatologist hat. I'm going to ask you to put on your NICU mom hat too. So when a NICU professional is in the NICU with a family and they suspect that the baby may have ROP, maybe in some of those early stages of ROP, or they may be susceptible to ROP, what do you think are some things that NICU professional can do to assist that family in understanding what is happening to their baby?
Yeah, that is so important. Bilingual professionals, and this will comprise a whole team. Your neonatologists, the advanced practice practitioners or APPs, nurse practitioners, physician assistants that work in the NICU. And we have some trainees in some teaching hospitals that would consist of fellows and residents. And of course, you have your bedside nurses who are the front line for care for this baby. And we're all part of one team. So it's important to let the family know that they also are part of their baby's care team, and that everyone cares about their baby. Like delivering any news, you have to be calm, you have to be gentle, yet honest, but still hopeful. In delivering any news to families about their babies, present things objectively, and not skew the presentation towards the more dismal prognosis. Right. Sometimes we try to be objective, but try to make sure they understand things can go wrong. So they heard it. And But, that doesn't help it.
Yeah.
Just be objective. You don't know, you don't know. And don't make 40% risk of neurodevelopmental disability sound like 100, just the way you're saying it. So it's a fine line. So I believe the first thing to do to support parents is build trust with your patient's family before you give them any news. Get to know them. Let them know you care and they're not alone. You care about not just their baby, but for them as parents and caregivers. Remind them to take time for self-care. You're there to care for the babies, okay. So
Yeah.
take some time also to take care of themselves. Then keep them abreast about the routine eye exams. And that I know that can be very daunting and intimidating, but they're very much like we're caring for the baby's lungs or the nutrition or any other part of a baby's body system. And it's just a vital part for the baby. Then it's okay to explain the process of eye development in a way, simple words they can understand. How the retinal vessels are not fully formed until the baby is full term. So invariably, a premature infant have retinal vessels that are not fully formed and haven't reached their periphery. And exposing them to oxygen, which is vital for their to stay alive and survive, could also affect the development of retinal vessels. You let them know that we're keeping on top of this by having serial eye exams. Now the ophthalmologist will come by once we've determined the baby is able to tolerate an eye exam, which is about 4 to 6 weeks of life, or post-menstrual age about 31 weeks. And then they're looking to see how mature the retinal vessels are. And if that maturity is in a safe place, they need to know about the macular, which is in zone 1. And that is an area of central vision and color vision. And you don't want abnormal vessels growing there. And if that happens, they're going to come more frequently, within a week or less, to see the babies. And as the vessels grow out, they extend the eye exams to about 2 to 3 weeks in general. I love pictures a thousand words. I love to draw rounds to depict lung physiology. And I also like to draw the retina to explain to the parents. I don't think it's too much information. We do show parents chest x-rays to explain lung
Right.
disease and show improvement of that. So I think having a picture of the eye in centers that do have retinal cameras is an important part of the medical record. And if you don't have that, being able to show them a picture from the internet or print one out in color if possible, or draw one like I do at the bedside for them, to explain how the vessels are growing, how it stops, and the different stages and zones is very helpful for them to be part of the process. Knowledge is power. It empowers them to follow along easily and not be so anxious about eye exams, because they do cause stress on the baby. I say the dilating drops make grown men cry. So imagine a premature infant
Oh,
getting
yeah.
those dilating drops. It's very stressful. They drop their heart rate. Sometimes they become apneic and stop breathing. Sometimes eye exams have to be stopped for the baby to recover. It may be postponed, which could be concerning if that baby has severe ROP. You want to be able to note that right away and treat.
Right.
So I think the goal of educating parents is to empower them. It helps them accept the eye exams with a thankful spirit. They know a stage 1 or 2, oh, I'm not so concerned. Well, that's good. We're still there. And if it progresses to a stage 3, oh, you caught it on time. We can do something about it. So yes, I believe in involving them in that process and educating them.
I'm glad you said that. I think sometimes maybe we're hesitant to give parents information. I was visiting with a surgeon not too long ago, and he said he always gauges, like, does this parent need photos? Do they need statistics? Like, what is it that they need that I can provide to them? And, asking those questions. So I think as NICU professionals are listening to this, they know, like, as you said, building that trust, they know those families. And so what is it that they need to feel comfortable with the care, but also to ask the questions? And I'm a big believer. I jokingly say I think most of us go to NICU school, so I may not have gone to medical school, but I certainly know enough to be dangerous. But it's because we asked questions and we had specialists who were
Mhm.
willing to give us good information. So information is power, knowledge is power. So I'm really grateful that you mentioned that. So when a baby is discharged from the NICU with ROP, so they've been diagnosed with ROP and it could be varying stages. What are some of the long-term care options for those babies as they leave the NICU and move into life at home? What can those families experience and expect, but also from a NICU professional side, what does that look like from their perspective?
No, thank you for that. Very important question. So as part of the NICU discharge planning, follow-up appointments are made for the baby's medical conditions that are still being monitored that but do not require inpatient hospitalization. So as long as they've met all the other discharge criteria, which could be feeding and growing adequately and breathing spontaneously without any oxygen supplementation or minimal supplementation with a nasal cannula device or other devices with a low oxygen need, and not have an active infection that needs critical intervention, that they're cleared to go home. So, but if the baby had not completed the ROP exam schedule, that needs to be continued as an outpatient, and the NICU staff is very diligent about scheduling this with ophthalmologists. So the dilated retinal exam should continue in the babies until complete retinal vascularization to the periphery of the retina. And that's typically about 45 weeks post-menstrual age, or there is a full regression of any ROP if the baby had ROP. And that means the vessels have vascularized all the way out to zone 3. And remind me, I have to go through the stages and zones of ROP after this. It's important to note that if the babies had any anti-VEGF therapy, they need to be followed up longer, because those have been shown to cause reactivation of disease in some cases, as late as 54 weeks post-menstrual age. And there are a couple cases that had reactivation of ROP up to 70 weeks. So eye exams for ROP, if there's full regression and full vascularization, after that need to continue on a routine basis, either at least once a year. ROP is a lifelong concern. We have seen babies have regressed ROP or no ROP or mild ROP that gets reactivated in their teens or later. So wow. That is important that if you've had a history of ROP, continue to have at least yearly eye exams after you've been cleared of either regressed ROP or a treated ROP that's no longer active. So what are the things you're looking for when you have those eye exams? They need to look from outside in. Basically, you're looking to make sure that they're checked for refractive errors, which would be like your myopia, which is your short-sightedness, hyperopia, long-sightedness, or astigmatism. That can be either or both those things. The ones that be more at risk with ROP patients is severe myopia. They become very short-sighted. They can't see things far away, and they need glasses or contacts to correct that. You also want to check their intraocular pressure to make sure they do not have glaucoma. And neovascular glaucoma has been seen as a complication of laser-treated ROP. You also want to make sure they have a good assessment of their anterior and posterior segment of the eye, and you want to look at their retinal blood vessels to make sure there's no reactivation of new ROP and that it's fully regressed. You also want to look at the optic nerves to see if it's hypoplastic, which means it's very small or poorly developed. And that can happen even in premature babies that don't have ROP. The visual consequence of that sort of varies from, no effect on visual acuity to needing a very high refractive error or having amblyopia where the vision loss cannot be corrected with glasses. So yes, ROP is a lifelong eye surveillance and care. And it's important that ophthalmologists and optometrists be aware that this, they need to continue to have a yearly, at least, care for these babies' eyes.
You are making me write down schedule optometry visit for my preemie, because I don't think I realized that it was a lifelong risk. And 2, that while the baby, your neonate may not have ROP, they may have other eye abnormalities or eye challenges that maybe didn't present in the NICU but present later. I'm an example of that. My son is, so I can definitely appreciate that. So you talked about stages of ROP, so let's go ahead and talk about those. I know you mentioned it, so let's do it before we forget about it.
I know. Yeah, so ROP is clinically classified or diagnosed using the guidelines set forth by the International Classification of ROP, ICROP or ICROP, and is done in stages and zones. So zones will refer to the area of the retina that's showing the vascularization, and you want to look at that area relative to the optic disc. So optic disc is the central part of the eye that contains your optic nerve that carries information to your brain. So zone 1 is a concentric circle centered around the optic disc that is about 2 disc diameters temporal, and that includes the macular. So I talked about the macular being your point of sharpest vision and color vision. You don't want bleeding in that part of the eye because you're going to be centrally blind. So when babies are being screened, the ophthalmologist is looking carefully for any activity in zone 1, and that would need closer attention or immediate treatment. Zone 2 is another concentric ring around zone 1, and these are hypothetical rings, like you're just looking at an area. And it stands from zone 1 to the nasal peripheral retina. And zone 3 is the remaining crescent-shaped area on the temporal retina. Now, stages refer to the vessel appearance at the vascular-avascular interface. In stage 1, they sort of like a demarcation line. So when the ophthalmologist looks in, they're not seeing a real line, it's a hypothetical line, but they could sort of tell where the vessels were growing towards the periphery and then abruptly stopped. Instead of a fine blending into the background, you could tell this is exactly where this vessel stopped to grow, and you can see the rest of the avascular peripheral retina. That is stage 1, is the beginning of angiogenic activity. So in stage 1 is low, mild ROP. They would, look at it again in 2 weeks. But if that stage 1, like I said, is happening in zone 1, where the macular, your central and color vision is involved, then they're going to look at it within a week. Yeah, stage 2 is the next form of ROP, and you now have a fibrovascular ridge forming at that vascular-avascular interface. So it's the next stage off from a demarcation line in stage 1. It looks like the vessels are hipping on top of each other. So sort of, if you will, when the ophthalmologist looks up, they could imagine running their hands over that ridge. It's not flat. You feel like there's a little mound forming. That's a sign of increased angiogenic activity underneath the deeper layers of the retina. So that is moderate proliferative ROP. And that needs closer attention depending on the zone, again, that is located or happening. Then stage 3 is severe ROP. And there you have pathologic neovascularization or extraretinal fibrovascular proliferation happening at the ridge. So you may see the ridge, but you also see tiny new vessels forming or branching out from it. Or you could, in some cases, see obvious frank bleeding in the eye. And this bleeding is coming towards the front of the eye into the vitreous. That is concerning. So severe ROP stage 3 that happens within zone 1 needs immediate treatment. If it's happening within zone 2, they could wait a week or 2 to see how it's progressing. Then stage 4 is the next phase of ROP. That is partial retinal detachment. So here, the retina sort of pulls away. The neurosensory retina pulls away from the underlying retinal pigment epithelium, causing like a traction. And how does it happen? So in stage 3, when the eye is bleeding, you have frank blood flowing around. What's going to happen with frank blood just flowing around? It gets congealed over time. And then it starts to become fibrous and start to attach to different parts of the retina, and then causes like a traction of pulling on it. And it can make that photoreceptor layer, neurosensory layer of the retina pull away from the rest of the eyeball or the retinal pigment epithelium of the choroid. And that is a detachment of the retina. And then you're not going to have propagation of retinal impulse or visual impulse to the brain. So that can cause blindness. So in stage 4 is a partial detachment where it's not the whole retina that's involved, a small area of the retina. And you have gradations of that. 4A would be if the macula is spared, is not involved. And 4B would be dragging the macula with it. Then stage 5 is total retinal detachment. You don't want that. And we're having less of that happening because of the very judicious and close attention to eye exams that are happening, and really good care in our NICUs. So there's some babies that will still progress there. But the retinal detachment in stage 5 is tractional, like I explained, and can be funnel shaped. They have a phenomenon called plus disease. I talked about it earlier. is a marker of how severe or more severe ROP. So it can happen at any stage, and it shows dilated and tortuous vessels. And from our research, my research, I've seen that the dilation is more occurring in the veins, and the tortuosity or a winding pattern is occurring more in the arteries. And if this is happening around the optic disc, is a plus disease. So if you have a lower stage with a plus disease, you may need a closer, like within a week follow up to make sure it's not progressing to bleeding. Then lastly, we have a term called, used to be called APROP or aggressive posterior ROP. Now in the recent ICROP 3, it's been renamed to aggressive ROP or AROP. And that is characterized by a very rapid onset of abnormal vascularization and severe plus disease that doesn't necessarily progress through the stages 1, 2, 3. And it can just go from 1 to, the detachment or stage 3 needing treatment. And it happens mainly in the posterior zone 2. So posterior zone 2 is just right at the margin of zone 1 and zone 2. But the new classification as AROP acknowledges that this can happen beyond the posterior retina. So this is the clinical classification of ROP.
That was fascinating and super helpful. So I hope that for people can rewind and listen to all of that again. That was really, really good. So I know that we talked a little bit about the interconnectivity of organs. Are babies who are diagnosed with ROP at a higher risk for other complications with other organs? I'm going to assume yes, but I'm curious what those are.
Yes. That is, I guess, how we find or identify those babies. Yes, we are all connected. And like I say, the eyes are the window to the rest of your body. That's why I love the eyes and organs so much. It's the only part of the body you can directly visualize blood vessels non-invasively by looking into them. So ROP affects babies that I said are lower gestational age, born less than 30 weeks, or birth weight less than 1,500 grams or smaller. But also there are risk factors prenatally, perinatally, and postnatally that put babies at risk for ROP. So some of the prenatal risk factors that would be prolonged rupture of membrane in the mom, premature rupture of those membranes, or moms that have hypertensive disorders, or infection of the placenta like chorioamnionitis. Perinatally, babies that are born with low APGA score that need more intense resuscitation at birth with oxygen have been found to have a risk factor for developing severe ROP. Of course, postnatally, having received oxygen puts you at risk. And then how long you got that supplemental oxygen, either non-invasively or invasively, also puts you at risk for developing ROP. We found ROP coincides or corresponds to lung disease, pneumonia, as well as, most importantly, bronchopulmonary dysplasia or BPD. This is lung disease of prematurity, just from the babies initially having low surfactant and needing having very immature lungs and needing oxygen therapy to inflate their lungs and conduct gas exchange. These babies are prone to intermittent, prolonged hypoxic episodes where their blood oxygen drops, their saturation drops, and then comes back up. Those fluctuations put them at risk for ROP. So more severe lung disease, we found those babies have more severe ROP. There are also hematologic risk factors. Babies that need frequent blood transfusions, babies that are severely anemic, and these affect blood vessel formation in the retina. And babies that have necrotizing enterocolitis is inflammatory infection of the gut from just being immature and after babies start getting feeds. So baby with neck, which can also cause rupture and perforation of intestines and need surgery. Those babies are at risk for severe ROP. And also intraventricular hemorrhage, bleeding in the brain in these premature babies that have very fragile capillaries in their brain watershed area. Those babies with intraventricular hemorrhage or IVH have high risk of getting ROP. And the other two things I would like to talk about, postnatal infection. The fact that babies are exposed to inflammatory cytokines or inflammation in their system puts them at risk. So babies that have early or late onset sepsis this will affect the retinal blood vessel formation. And I believe that from my research, I've seen that ROP doesn't just affect retinal vessels, it affects both the structure and function of the retina and also has an inflammatory component to it. So babies that are exposed to high levels of cytokines from birth through infections or inflammatory conditions are at risk for ROP. And I had talked about growth. It's always a challenge to give enough calories to these premature babies and have good post-uterine, postnatal weight gain that matches their intrauterine growth velocity. So we've seen that slow weight gain from studies have also babies that are either intrauterine growth restricted or have poor postnatal weight gain are at risk for severe ROP. And I've also seen that in my animal studies.
I'm grateful that you mentioned that. One, because I think sometimes we hear about a specific condition and then we worry about all the other things that could go with it. I want to offer this. My son was IUGR, so growth restricted. He also was a surgical necrotizing enterocolitis baby, and escaped the NICU without ROP. We get him screened regularly, but I think that it's good to know what could be, but it's also good when you were talking about hope to remember that just because all those
Yes,
things could happen doesn't mean they will.
exactly. Exactly. No, I'm glad you mentioned that. Yeah, for each of these things I've mentioned, there's a risk involved, there's a percentage.
Mhm.
It could be
Right,
5 to 10% or higher or
right,
lower. And that's just what it is, a risk, an
right.
expectation. And that has nothing to do with the individual outcome for each baby, which may differ. And catching these things early, treating them early can actually help the baby have a better outcome and escape the worse effects of RP.
Right. I am gonna put in a plug. A few months ago, we did a podcast with Dr. Catheria. He's out in San
Mhm.
Diego, and we were talking
Mhm.
about surfactant. So as you mentioned that, I was thinking they have things that they're trying to administer
Yeah.
surfactant in a different way, which takes babies basically off ventilators and off
Mhm.
CPAP machines. And as I'm listening to you talk about the role that oxygen plays and his desire to reduce the amount of oxygen that babies need, I'm seeing all these dots connected. So if you need another
Yeah.
good one to listen to, that's a good one. So I have just two last questions. So prevalence of ROP globally, domestically, what do you see in your research? What's the prevalence of ROP here in the States versus what you see outside of the United States?
Yeah, that's a wonderful question to sort of start to end with. Um, well, the prevalence of ROP has been increasing with increased survival of premature babies as we've had improved technology in obstetrics and perinatal and neonatal care. And we talked about it being most prevalent in premature and low birth weight babies, especially babies less than 1,500 grams and less than 30 weeks gestation. And it has been, ROP has been identified by the World Health Organization as a major cause of preventable blindness worldwide in children. So globally, you have about 15 million babies, or 11% of babies that are born preterm less than 37 weeks, um, being born premature annually. And of that, an average of about 184,700 premature babies develop any stage of ROP worldwide. And those studies are from like 2010. And of which only about 10.7% will develop severe visual impairment. So globally, we have about 50,000 children each year blind or severely visual impaired from ROP. And in the US per se, we're looking at a prevalence of about 14,000 preterm infants that are diagnosed with ROP every year, and 7.8 to 10.7% of them requiring treatment for severe ROP, which amounts to about 1,100 to 1,500 cases a year of severe ROP that needs medical attention or treatment. In spite of that, we're seeing 400 to 600 infants being completely blind from ROP in the US alone. And the global rates for this sort of differ from countries. And that relates to the infant mortality rate. Those with a high infant mortality rate may show less prevalence of ROP because those tiny babies are not surviving. They don't have the resources for them to survive much smaller in gestational age or weight. Then you have high income countries may have a low risk of ROP blindness because they have available resources and technology. And then we're having sort of a third epidemic of ROP, if you say, in middle-income countries who are having a higher risk of blindness because they have more resources available, they're improving the NICU technology, and they have an increased survival of babies that are smaller and lower gestational age. But despite the resources, it's still inadequate to meet the needs of this ROP baby. So we're seeing a higher risk of blindness in the middle-income countries. So example of those, the middle-income countries, you would have places like Iran that will give you about 27.2% prevalence. So Indonesia would have a range of like 11.9 to 30.5% prevalence. And in low-income countries, India will give you about 30.1% prevalence. And in Africa, it varies widely. You have Egypt ranging anywhere from 19.2 to 69.4% prevalence. And Nigeria has a prevalence of 47.2%. And the incidence there actually varies from 5.5 to much higher, more than 47%. So these regional differences within nations and among nations is a huge disparity that shows the inequity in either healthcare access in the low income regions of those nations and resources, or inadequate, poverty and inadequate resources to afford healthcare if it's available. So yes, there's a huge discrepancy and disparity in ROP resources and prevalence worldwide.
Yeah, and I would suspect that's not just unique to ROP. I'm sure that's unique to many things that preemies are challenged with. I always like to ask, this is my last question because I like to hear people dream a little bit. So if you could think of maybe one area that you're like, man, I would really love to see us have a breakthrough in this particular area, or my clinical studies, I'm moving into this area, like what would you dream may happen in ROP research throughout your lifetime?
That is a wonderful question to end with. A lot of things. So I'll just say a few, I guess. Drug therapy, for one. There's no known drug to prevent it that completely treats it without systemic side effects like we've seen. So I would like to see improved local drug therapy for ROP. ROP therapy, I believe, should be localized to the eye be treated with minimal systemic effects. It should be safe, non-toxic, and targeted to specific mechanisms in the eye. And we now have wonderful methods of delivering drugs to the eye that make sure it's not absorbed into the system. One of them is using nanotechnology. Nanoparticles is one of the things I'm studying in my lab, where we can locally deliver drugs to the eye, targeting a specific either cell or pathway. So I think that will help, advance safe therapies that do not affect other organs, especially if you're trying to block a pathway that is shared by other organs, like we talk about VEGF. And VEGF, for example, is a very complex protein. We talk about it being upregulated in hypoxia and downregulated in hyperoxia, but it's not that simple. It's a complex protein with different forms. So it has VEGF A, B, C, D, E, F, and each one of them has at least 5 isoforms, and each isoform has splice variants. If the gene is spliced proximally, you have a pro-angiogenic isoform of the gene. If it's spliced distally, you have the anti-angiogenic. So I believe, so targeting things like those growth factors have to be specific and targeted to a biphasic therapy. So if you're going to do pro-angiogenic therapy, you want to target it early in the first 4 weeks of life, where you want to stop the high vasoarbitration and allow more vessels to grow. Then after 4 to 6 weeks, you want to target anti-angiogenic therapy to stop excess bleeding from happening. So I'd like to see research in ROP being targeted that way more specifically, so we can reduce systemic effects. Then also, I talked about there being a concern about so many babies needing screening. And we've talked about globally where some remote areas or resource limited areas don't have access to screening or even the manpower for ophthalmologists to reach some of those remote areas. So retinal cameras have become a big thing and very helpful in ROP diagnosis in some of those remote areas, where they can be captured by local staff who are trained to use those cameras and remotely read. But we're having a problem in that, one, some of the camera qualities are not coming out with great pictures. It could also be the technique or whoever is capturing it, but it's been very hard to use retinal cameras in multi-centered studies. And I was part of a study that tried to look at retinal camera use to look at drug therapy for ROP. And it was very challenging because there was varied expertise of using it or discrepancy in reading it from different areas. So I would like to see more portable, accessible, and more quality, image quality improved in these retinal cameras where they're capturing images faster, more efficient, and you're transmitting them easily back and forth to ophthalmologists to read and identify this is a severe ROP, it needs to be treated within 48 to 72 hours, and then you can have access to care for those babies. And in that vein, I would like to see more application of artificial intelligence. We have AI being rampant in all our systems industrially. We can also use it in the eye. So there have been a push for deep learning systems for ROP screening. It can help us with algorithms to either semi-automated or fully automate analysis of retinal images. So it's more objective, fast, accurate, and reliable diagnosis. So there are no discrepancies in reading stage 2 or 3 or plus disease or no plus, which could delay treatment. So this would be very helpful in resource-limited areas. And I would like to see stem cell therapy. We've had animal OR studies that have shown that stem cells are very promising. And this could be either harvesting bone marrow from the babies, from their bodies itself, which may be invasive and not desired. Or you can also harvest them autologously from their blood cells and umbilical cord blood or donor club blood. They also can have allogenic bone marrow matched with donors to avoid potential rejection. So these would give us the capability to have regeneration of the retinal cells that are damaged from ROP. My research has shown that the specific cells in the retina are damaged from ROP. The photoreceptor cells and the bipolar cells, after oxygen exposure minimized, there are fewer of them. And then the synapses or the connection between them are malaligned or ectopic. And we see cell death or apoptosis happening. So hopefully stem cell therapy could lead to targeting some of these specific cells and regenerating them to improve vision or preserve vision. And lastly, I want to see a more integrated approach to neonatal care. That is so important. And like we said, understanding that ROP prevention does not preclude caring for the lungs or the gut or the brain. Right. And actually, the retina develops alongside the lungs. And in the womb, hypoxia that's normal improves or allows vessel growth both in the lungs and retina. So treatments in the first 4 weeks of life to limit hyperoxia would help lung growth, would help retinal vessel growth in the normal fashion. And after 4 to 6 weeks of life, treatments to reduce hypoxic stimuli would help reduce severe ROP effects on the retina and as well prevent progression of lung disease or development of things like pulmonary hypertension from excess hypoxia in the lungs. So it's important to look at the eye as an integrated part for the baby and organs as all being connected. So these are like hopefully the things that I want to see happen in ROP advances for therapy.
You know, if you're not watching on YouTube, you should, because not that you weren't animated throughout the whole podcast, but I love hearing people talk about what they dream about, because I think that that's where we see your real passion. So Dr. Mezu-Ndubuisi, thank you so much for such good overview of what ROP is, what we know about it, what can be, and what will be, hopefully, through really good research and studies. So thank you for your expertise.
Thank you so much for having me. I appreciate being here. And thank you for the wonderful work you're doing, bringing this information in such a wonderful way to your audience, to moms that have babies that have these concerns. It's noble. I appreciate it.
Oh, thank you so much. Well, we will be back next time, so don't go anywhere. We'll see y'all next month, but thank you so much. Thanks, y'all, for listening to NICU Heroes. If you enjoyed today's episode, please don't be shy, y'all. You can share it, you can subscribe, and you can most certainly review it. We would love your reviews. It's how we reach more NICU professionals. I'll see y'all next time.